How is that possible? Like where does that happen? Anywhere. Where it's like, no, you have to go and do the visit, buy the product, even though you don't know what it is. And by the way, you can't return it. So it was just an amazing example of how broken our healthcare system can be. This is Sick Health with Kevin Ban, MD. Our show helps you navigate our broken healthcare system and take control of your own health. Hi, I'm Kevin Ban, an emergency physician with over 25 years of clinical experience. Most recently, I was the chief medical officer at Walgreens, where I led the national pandemic response.
Hello, I'm Alex Wallace. I am a longtime journalist. I was an executive at NBC News and most recently at Yahoo.
Healthcare is broken. Until we get it fixed, the goal of this show is going to be to keep you and your families out of the healthcare system. Now, there will be times when it'll be necessary, and we will be here to help you navigate.
The best way to support this show at no cost to you is by subscribing to our YouTube channel, Sick Health with Kevin Ban, MD. So today we have two cases. Case one is going to be on all the new diet drugs. I mean, there are just, you can't turn your head, call a friend, scroll through your feed without hearing about one of the new weight loss drugs. I know they're actually not weight loss drugs, but we'll get to that. Case two is something interesting. It's called price transparency, which I actually did not know was something that existed in the healthcare system. And Kevin's going to tell us all about it. But let's start with the new class of healthcare drugs, the GLP-1s. Let's start with what are their names? I know some of them.
That's pretty confusing, right? Like you hear, what have you heard? Have you heard of Ozempic? I'm pretty sure that Wegovy, Zepbound, Mounjaro. So let's start with the really basic understanding of what they are. For the most part, and let's start with Wegovy and Ozempic. They are actually made by the same manufacturer, Novo Nordisk. They are actually the same medication, but Ozempic has FDA approval for diabetes, whereas the Wegovy, which is the medication that's used in obesity, that has FDA approval for that cause, obesity. Now, the same is true with Mounjaro. That's for diabetes. And for Zepbound, that is for weight loss. So right out of the gate, it can be kind of super confusing. They're often, the class is referred to as GLP-1s, glucagon-like peptides. So we'll get into that.
Okay, so explain to me how the discovery, it was a side effect. These are, at least some, if not all of them, were to treat diabetes. And it turns out that a side effect or off-label use is weight loss. Is that correct?
That's right. So first of all, folks have been talking about these medications and saying, oh, they're really new and we don't know that much about them. And the truth is that they have been used for over 10 years in diabetes. So we know a lot about them. What people recognized is that while they were taking the medication for diabetes, they were losing weight. And sometimes 10% of their body weight, 15% of their body weight, sometimes more. And so that's when, people took a step back and said, hey, could this also be a treatment for obesity?
And how do they actually work?
So, okay, let's go all the way through this. I love to do the physiology, and the reason I'm smiling is because it's just we're about to get into physiology.
No, and I saw your face, and I was like, I might have to go get a snack because it was like that's your face when I've got a very long explanation coming.
It's kind of like the first time we met. I felt like you asked me a question, and then I was answering, and you just left, and came back 15 minutes later. All right, let's get into it. So what is insulin? That's where I'd like to start. It's a hormone. And one of the things you should know about hormones is they sort of turn on a process in the body. Much like you have electric receptacles in your house that if you want to plug in a lamp to turn it on, you take the plug and plug it in. That's not how a hormone works. It's created in the body, moves to another part of the body, and it starts some sort of process. The way these medications work is that they go to the pancreas, they go to the brain, and they go to the stomach where they have an effect, okay? In the pancreas, what happens is they go there and they stimulate the secretion of insulin. And in the previous show, I was talking about how important it is to keep blood glucose and insulin stable. That's what these drugs do. They go to the pancreas so that your body secretes insulin, and that keeps your blood glucose stable. But that's not the only place that these drugs work. They also go to your brain. Okay. And in the brain, and quite honestly, Alex, this mechanism is a little less clear to us about exactly why. But in the brain, they get rid of that drive for appetite, but they also get rid of something called food chatter. And food chatter is something where people almost obsessively are thinking about eating and about food. These medications, and we don't really know why, seem to quiet that chatter. And then the last piece of it is it hits your stomach. And here in your stomach, it decreases the emptying from your stomach. So when you eat, you actually feel full longer. Okay. It decreases what we call, and here's the fancy term, gastric emptying. And so it keeps that sensation of being full. So that is the way that these medications work. Again, in the pancreas, in your brain, and in the stomach.
Yeah, it's interesting. A good friend of mine is taking it, and for years she's wanted to lose 40 pounds, and it has helped her do it. And it's funny. I don't know if it's the words is satiety, but she feels that she eats a certain amount and then she feels full. And she said it's just kind of great. It's not like you just don't want to eat anymore.
Yeah, that's exactly how these medications work. And it's the combination of those three things that, keeping the blood glucose stable, decreasing that chatter, getting rid of the sensation like you're hungry, and then also the gastric emptying. All of those come together to make this a very, very effective drug.
So who should take these drugs?
There are some very straightforward guidelines about who might be eligible to take the medication. The first is any person with a body mass index, or the BMI of greater than 30. If you fit that criteria, you are eligible to get this medication. But it's not just those people. People who have a body mass index, a BMI of greater than 27, and also have an obesity-related illness are also eligible. So this is really important. What is an obesity-related illness? Well, if you also have high blood pressure, diabetes, high cholesterol, sleep apnea, and then one I really think is important and I want to shout out, and that's polycystic ovarian syndrome. So if you have any of those, along with a body mass index over than 27, you're eligible.
That feels like a large group of people. If you fit that criteria, you are eligible. You can go to your doctor, and if you have insurance, it will be covered.
Well, slow down, not so fast, almost. So if you meet those criteria, then your doctor can prescribe the medication, and then it depends. Okay. It depends on your insurance and how many times have you heard that. What will likely happen is that it's going to go for pre-authorization, and they're going to make a decision as to whether or not you should be on that medication. So you're not really in the clear here. The other thing is that we have to remember that there is off-label use of medication. So if a drug is FDA approved, in this case, for example, diabetes, a physician can still prescribe it off-label to treat someone, even if they don't have an indication. And that's how you're seeing people who don't meet these criteria, but who are taking the medication, right? That is being prescribed to them, likely off-label.
As we were talking, prepping for this show, you made a big point about treating obesity as a medical problem, not a lifestyle problem. And I think it only got categorized as a medical problem in this country just over a decade ago. Is that right?
Yeah, it's exactly right. It really feels like we pay lip service to the concept that obesity is a chronic medical problem. The WHO recognized obesity as a chronic medical problem back in the 40s. Okay. You're exactly right. We here in the United States didn't recognize it as a chronic medical problem until 2013. So just over 10 years ago. And the truth is that we're still not treating it like a chronic medical problem. To a certain extent, we think we act like it's a willpower problem. And that's not fair to people.
Okay. We talked about who should take it. Who should not take it?
Right out of the gate, if you are pregnant, if you are or you're trying to get pregnant, if you are breastfeeding, you should definitely not take this medication. Now, earlier when I was talking about the mechanism of action, I talked about the pancreas. So if you have a history of pancreatitis, you shouldn't take this medication. And I should mention, if you don't know what pancreatitis is, it means you don't have it. So don't worry about it. Now, thyroid cancer, those folks shouldn't take it. That one is a little less clear to me, quite honestly. It seems like that data or those data come from mice, and that may not pan out. But for now, if you have a history of thyroid cancer, you really shouldn't take it. And then lastly, there's something called Men's syndrome, which is multiple endocrine neoplasias. Again, if you've never heard of Men's syndrome, it means you don't have it.
Like all medications, I'm sure there are some side effects. Which are the most common?
Yeah. So again, I want to take us back to our physiology lesson where I talked about the slow gastric emptying. That's the effect on the stomach or the gut. And what happens there is that many people will experience nausea. Some people will have vomiting along with the nausea. There can be abdominal cramping, abdominal pain. So that's all because of the impact on that slow emptying in the stomach. What's interesting about it is that these side effects are usually pretty transient. They'll go away, but some people just can't get over the hump. And as it turns out, they just can't tolerate the med.
What about kids? Has this been tested in kids?
Yeah, so the kids are really it's a controversial topic, I will say. First of all, the medications have been approved by the FDA for people 12 years and older. Okay, so that's straight out of the gate. If you're younger than 12, there is no indication to give it to those kids. But there's a lot of controversy around this. The American Academy of Pediatrics came out and said, yes, it makes sense to use this drug when appropriate. I think we have some ground to travel here about what the right thing is. But what I will say is it has to be incorporated in a bigger plan. So it should not just be give the kid the medication and go from there. It should also incorporate lifestyle changes. So whether that's their diet, how well they're sleeping, whether or not they're exercising, it's really best to incorporate all of that and then also use this drug to help.
Got it. Okay, food chatter. There are other things that your brain can become obsessed with and or addicted to. Drugs, alcohol. Is it possible? I know there is some data that these drugs might work for other kind of cravings. Where does the testing on that stand?
I really want to avoid hyperbole when I answer this question because I think it really, for the most part, it doesn't pan out in medicine. So I will say this. You are 100% right. These drugs should not be thought of as anti-obesity drugs. They should be thought of as anti-craving drugs. Okay. And what I mean by that is there are studies that are happening right now, and we're seeing early data where it's useful in alcohol or against opioid use disorder, people who gamble, people who smoke. So this is not just about cravings for food. This is an anti-cravings drug in general. If that turns out to be true, and the side effect profile and the safety profile pan out to be acceptable, then this could really be a transformational medication. Now, there's a lot of assumptions in that. There's sort of a lot of road that has to be traveled. But if those things are all true, this may be the most impactful drug that we will see in our lifetimes.
I was just going to say scientists/doctors never say things like that. And I know it's not fully proven out yet. So is this similar potentially to the discovery of penicillin, potentially the statins? I know when statins came on the market, they were a new class of drugs. This feels like kind of how AI is the next huge leap forward.
I think that the answer to that question is yes. If these truly end up being anti-craving and they work across so many different patients, and then add to it one other thing that I should mention, which is that these drugs are cardioprotective. So there was an article in the British Medical Journal last summer, and then in the New England Journal of Medicine in December, and they took a look at people who had heart attacks and strokes that didn't kill them, but then also all-cause death from cardiovascular disease, and they found that there was a huge decrease. How big? About 20 to 25%. Okay. Now, just to give people some context here, when you're talking to a doctor, we think of 3 to 5% as being, a big deal. When you start talking about 20%, it is an enormous deal. So when you put all of that together, that these drugs prevent heart attack and stroke, so they're cardioprotective. You put it in with that they're very good weight loss drugs that will allow people to be more active and really live more healthy lifestyles, and that they could also prevent alcohol use disorder, opioid use disorder, help with gambling and smoking. It's a blockbuster drug.
These are really expensive medications. And, I have a friend who would like to have her daughter on it who's in her 20s, but cost is a factor. Are there any other drugs? And in fact, you shared with me an article from The Atlantic that there are actually older drugs. They may not be as effective. The weight loss may not be as large, but there are other drugs that come at lower cost that you can also try, correct?
If you don't get anything else from this show today, please walk away with the GLP-1s are not the only way to treat obesity. We really have to think about treating obesity as a chronic medical problem. I want to hit on that again. What does that mean? When you come in with diabetes, new onset diabetes, or high blood pressure, high cholesterol, what do? We immediately give you a medication, and then we work on lifestyle changes. The lifestyle changes can prevent about 80% of disease, can even treat a significant amount of disease to get you off those medications. We should do the exact same thing with obesity. When a person comes in and they've been struggling with this diet and that diet and have tried lifestyle changes, start them on a medication. Now, it may not be possible to start them on a GLP-1, but now to your point, there are other medications that work. And when you put some of those medications in combination, so you may have to take 2 meds, they start to, really do a good job of helping people lose weight. How good of a job? I mean, when you combine some medications, you can get up to like 10% of body weight. In some people, it could be higher. So don't despair if you can't afford a GLP-1. Quite honestly, I wouldn't want to do that. But if you think it'll help you on your journey to treat chronic obesity, then make sure you talk to your doctor. Alex, here's the last thing. Not all primary care doctors feel comfortable doing this. And so, some do, but it may be necessary to see an obesity specialist. They've been using medications for over 15, 20 years. They can help.
I live in New York, and there are definitely women here, and I'm sure men too, who are taking it off-label and have been prescribed it off-label. Is there a downside to that as long as there's no limitations on availability of medication? Obviously, if there are limitations on availability of medication, then diabetics and people who have medical needs for it. But is there medically a downside to doing that?
So I'll answer that question by saying, not really. These medications so far seem to be safe. Okay. And like I said, they're not new. So we do have data on them. Having said that, you hit on it. These medications are not available. We just don't have enough of them. Let me give you an example. When during the pandemic, we had new vaccinations, and that I led the pandemic response. It's how we start the show for Walgreens. There just weren't enough medications. Okay. And over the course of time, we had more and it became okay. That is not what's happening here, Alex. These medications are under severe demand by people who are diabetics and need them, but also by people who are trying to lose weight. And so there's a problem there, right? There's tension there. And my take on it is, look, we should prioritize the people who really need the medication because they're diabetic and it's the best medication for them, or because they meet criteria and it's going to really do a good job, or because they have been trying to treat obesity and it's not working for them, and they've even tried the other medications, so now that's for them. So I think look, you've got to tolerate the fact that some people are going to use it off label. It was like that way with the vaccination. We rolled out the vaccination across the country. Like 90% of the people, waited and did the right thing. There were 10% of the people who, kind of jumped the line. Okay. And what the guidance that I gave to the pharmacist is, don't worry about that. 90% is really, really good. Don't worry about the 10%.
Okay. So I want to try and sum it all up. So here's what I took away. A lot of people eligible, which is one. Two, this is really potentially, I don't know, if I'm not a doctor, so I won't use the word breakthrough, but this has the potential to be a real game changer. Three, it appears that it doesn't just work on food chatter. It appears to work on other addictive behaviors. And four, that there are also other older drugs. So if it's too expensive, if you don't qualify for it, don't despair. Talk to your doctor about the other older class of drugs that are much less expensive.
That's exactly right. And there's a lot of chatter about the GLP-1s. They are potentially an exceptionally important drug. However, they are not the only drug. You said that. Just wanted to hit it again. So please make sure you ask your doctor about it. It could really make a big difference.
Got it. Okay. Case number 2, Dr. Ban. Recently, you shared with me a post that a woman posted on X. And it was a fascinating story of an encounter she had with a receptionist at her doctor's office that brought to light something that I actually did not know existed in this country. Tell me what happened to her and what all of us should do if that happens to us.
The person did not have healthcare insurance. Okay. And so went to the doctor's office and sort of asked, hey, how much is this going to cost? And you got into this kind of crazy situation where it was like, well, we can't tell you how much it's going to cost until we've done the visit, which is like completely crazy. And so I think this person was like, how is that possible? Like, where does that happen anywhere? Where it's like, no, you have to go and you have to, do the visit. You have to do sort of the, buy the product, even though you don't know what it is. And by the way, you can't return it. So it was just an amazing example of how broken our healthcare system can be.
Just walk me through that. So if I go to the doctor, I can say, what is an MRI going to cost me?
Right. So look, this is really new and it's very important. And I don't want to overcomplicate, but I talked about someone there who doesn't have healthcare insurance. But let's think about people like me, potentially you, who have high deductible insurances. We have decided to keep our premiums down, but our deductible is super high. How high? My deductible is $6,000 for myself and for each one of my dependents. Okay. As a family, it's $12,000. So for anything preventative, that's covered. But for anything that's not preventative, you have to pay out of pocket $6,000 per person or $12,000 for the family. I mean, that's a huge number. So what that's forcing us to do is become consumers. Okay. And that's what that person was trying to do in the doctor's office, saying like, hey, how much does that thing cost? And the truth is, we're not set up for this, right? A CMS, that's the Center for Medicare and Medicaid Services, okay, a really important institution, is really pushing price transparency. And that's something people need to know. This started back in 2022. It's progressed in 2023 and now into 2024 with different laws that say and here's now finally the answer to your question, you have the right to ask how much things are going to cost before you do them. Now, I should mention, like parenthetically, that scares me a little bit because I'm afraid people won't get the care that they need. But you certainly have the right to ask how much it's going to cost. And that will help us become better shoppers. When we have price transparency and when we have quality transparency, then we can know what we're getting.
You're talking about something that we're going to try and talk a lot about in this show, which is moving in some ways from the passenger seat to the driver's seat in terms of your own health. I mean, I do have to say, I have deep respect for doctors. And if the doctor tells me, I mean, I wouldn't jump off a bridge, but I would do most other things they tell me. But what you're saying, and that the patients also have to have the right questions, and you have to go in and you have to become a more active participant, not just with your doctor, but with your health in general.
That's exactly what I'm saying. You know, for a long time, we've had a very paternal healthcare system where the doctor tells you the way it's going to be. And we need to flip that on its head because things have changed. The number one cause of bankruptcy in this country is because of healthcare bills. Okay. I want to prevent you from getting there, people. Don't let it happen. So know that you are in the driver's seat. A more healthy way to think about your relationship with your doctor or any type of provider is that they're your consultant. They are your partner. You work together, but you are equal 100% in the relationship. So I want to encourage you to ask the questions. Now, I'm going to go back to a concept I've shared before, which is you need to be proactive. Okay. If you find yourself at the front desk of a doctor's office trying to figure it out, you're already like behind the 8 ball. What you need to do is in advance, you need to have made that phone call and to ask, because it is absolutely possible for the doctor and the staff to be able to give you information about how much things will cost.
Got it. That's really helpful. Thank you.
The other thing that's really important to know is that the prices for different procedures, for different tests, can vary. I'll give you an example of that. My daughter, not last summer, but the summer before, needed a bunch of testing. Okay, get in front of this and say she's totally fine. But she went across the street to a hospital. Interestingly, it's the hospital where I used to be the chief medical officer, which was probably the most expensive place for her to get those lab tests done. And the doctor didn't give us a choice. You know, the truth is we could have gone to LabCorp, we could have gone to Quest, but instead we went to the most expensive hospital. And then later she needed a referral to the Children's Hospital in Boston. All of that ended up costing over $3,000. Okay. And I never once got an opportunity to ask, like, hey, is there a more affordable option here? Now, I'm not looking, it's really important how I said that. I'm not saying a cheaper test. I want a test with equal quality, but one that costs less, because that's very high value. And I'll tell you, I got burned once, Alex, but it won't happen again. I ask now, and I think people need to know that they can ask. So when your doctor or any healthcare provider wants to do any type of testing, whether it's an X-ray, an MRI, a CT scan, lab testing, urine testing, whatever it is, ask the question, what are my options here?
It's great. I would not have thought to do that. So thank you. Okay. We covered 2 cases today, GLP-1s and price transparency. But as Kevin and I have been discussing this show, there are many, many topics. It's fascinating. Probably 10 a day that we think of. But what we really want is for you all, the audience, to come to us and tell us what topics you want us to cover. What things are you running into in your life, whether it's with the healthcare system, whether it's with your own health? Please go into the comments section on YouTube at Sick Health with Kevin Ban, MD, and let us know. And as many of them as we can cover, we plan on doing.
All right, we're going to land here again with sharing beauty, Alex Wallace. Is that cool with you?
Yes.
Okay. I'm not sure that Alex is perfectly bought in yet, but folks, please be bought in on this. Let's share some beauty. And by the way, I want to say, if you can send me some beauty that I can share on the show, I would love to do that. So in my family, we, for over 10 years, 12 years, I'm going to actually ask my wife how long we've been doing this. We have decided to share beauty. What does that mean? As you're driving down the highway and you see a beautiful field or a sunset, we shout out sharing beauty to make sure everyone sees it. It was really fun when the kids were young. We still do it. My son's 19, my daughter's 16. Actually 17 next week. And so we do it also in our family chat, in our stream. our text stream, and we'll drop in videos. And so what I'm going to do is to just drop in some of the things that I think are absolutely beautiful. And today's comes from David Foster Wallace. He gave a commencement address in 2005 at Kenyon College, and it's called "This Is Water." Okay, and I have been watching this and rewatching this for over 7 years now, and what I would say about it is it reminds us that we are not the center of the universe all the time. Now, look, often ask Alex. I feel like I am, right? Like that's my point of view. I'm looking out into the world, but it reminds me that we're not the center of the universe. And so it's something that's really interesting, and I hope you'll watch it and enjoy it.
You'll drop that into the as a link under the YouTube channel, on our YouTube channel too?
Yeah, actually, Chev, keep me honest on this one. Make sure that you drop that into the show notes, and we'll make sure that everyone can see that. I just want to thank everyone again for being a part of our community. I want to reiterate what Alex said. Let us know what you want to hear about, and we'll be sure to touch on it. Till next time, I'm going to say thank you very much. I want to thank our producer, Batsheva Gez, who has been everything to us. So, Chev, thank you.
Thank you, Chef.
This show's content represents the personal opinions, of Alex Wallace and me. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not create a physician-patient relationship with me. Always seek the advice of your physician or other healthcare qualified provider with any questions you may have regarding your medical condition or your general health.
I give you a B-.
That was terrible. Oh my God, let's keep going though.